Welcome to the Dear Menopause podcast, where we discuss the menopause transition to help make everyday life a little easier for women. Hey there, this is Sonia. I am the host of Dear Menopause, and I am a fierce and at times impatient advocate for women's health. Today, my guest is Dr. Louise Newson. Louise is one of a few top UK experts on the menopausal transition, and she has helped hundreds of thousands of women through her clinic, app, and websites. Settle in, enjoy this absolutely brilliant chat between myself and Dr. Louise Newson. Dr. Louise Newson, welcome to Dear Menopause.
Thank you. Thank you for inviting me.
It is wonderful to have you here. Now, for any listeners that are not familiar with who you are, and I'm sure there might be some out there, why don't you give yourself a little intro and tell everybody who you are, a little bit about the background of Louise Newson and the Newson Health Group.
So I'm a GP, so family physician, but I've also got a pathology degree and I trained in hospital medicine for many years and then pivoted into general practice. But the last 7 years, since the NICE menopause guidance came out, I've dedicated my time, effort, energy into looking after women who are menopausal or perimenopausal. And 5 years ago, almost to the day, we opened a clinic, Rebecca Lewis, who's another doctor, and myself, because we started to see this massive unmet need for women who are just being underserved, not listened to, and not able to receive the evidence-based treatment that they need to improve not just their quality of life, but their future health as well. So we set up the clinic, and then the stories that we heard were very distressing. I'd also started to play with the media and social media because I thought, actually, why do I have all this knowledge and other people don't? And it's all very well me having the knowledge as a healthcare practitioner, but actually as a menopausal woman myself, I want access to information so that's not biased, that's not funded by pharma, that I can just make decisions myself about my future health. And then we decided to develop and launch the Balanced Menopause app, which came out about 3 years ago. And then we've also worked very hard on education as well. So we've just actually relaunched our Competence in the Menopause course that is now actually available for anybody. So I don't care what job they have or if they don't have a job. I don't care what gender or sex they are. Anybody can access the same information as healthcare practice.
Yeah, so let's talk about that for a moment, because that course you originally launched for medical practitioners, didn't you?
You know, in medicine, I mean, I'm really embarrassed that I didn't have any menopause training. And I look back with horror some of the things that I had said to patients that I just hadn't thought about the menopause because I didn't understand, didn't know the myriad of symptoms, didn't really understand how easy it is to prescribe HRT either. So I learned a lot by sitting in other people's clinics. But actually, it's not practical to sit in other people's clinics. And some training programs say you have to sit in and write up cases. Well, in my mind, any healthcare practitioner who has an interest in the menopause should be seeing and helping women, not sitting in observing. So what I decided to do many years ago, so before COVID, before we did all this online work, I decided to make a course that was available online that people could do in the comfort of their own homes. They didn't have to take too much study leave and time. But also we filmed actresses. So we filmed ourselves with actresses who are pretending to have different symptoms and different histories, so that you could really see a select group of women who people are likely to encounter in their medical practice. Mm-hmm. And we've linked everything to the available evidence, to papers, but also to resources, because as you know, I've also been a medical writer for many years. So we've got a huge amount of information on our website, on my podcasts, on videos. So we've linked all that as well. And we had over 30,000 downloads of the course with the most phenomenal feedback from GPs, nurses, pharmacists saying it's changed my practice. I've got so much more confidence in diagnosing, managing, talking to patients. So what we then decided to do was to revamp it really. Now I'm fortunate I've got a lot more people working with me. So we've got a lot of our clinicians to review it. We've got an education lead, we've got an editorial lead. So we've gone through it all and updated it. Put it under different platforms so we've got more control over it, which is always good to have the control. But what we decided to do was make it available to anybody. So some of it's free, some of it's paid for on a subscription, but all that money is just going to be recirculated back into funding more education, but also some research, which is really needed.
It's fantastic. And I love that you have opened that education portal up to everyone, because I think, here in Australia, I feel very much that we are following the lead of what has unfolded in the UK. And it was one of the reasons why I was so excited and keen to get this opportunity to talk to you, because I feel that there's so much that we can learn from what you have experienced, what you have, what's played out in the UK, as to we can learn from your mistakes, we can learn from what worked, what didn't, and then we can implement that here. And I truly believe that one of the biggest and most fundamental things that we can be doing right now is education. And that's education across all facets. So it's education of women at the fundamentals, it's education of our practitioners and, like you say, nurses and allied health. It's education of medical students that are currently in their curriculums at university. Education is just so important, and it's something that's really lacking here in Australia right now.
Absolutely, and it is everywhere actually, and there's so much misunderstanding. And even the work I do, a lot of people are looking at England and saying, "Wow, it's so good," but actually, it's not. I spend a lot of my time really frustrated. There's still the people of influence are listening to wrong things. They're not reading the data. They're not understanding the evidence. There's still this sort of frivolous thought that, HRT is just a lifestyle drug. People take it because they want to look like celebrities. Well, the number of women I've seen who have been suicidal, who have been really distressed, who have been taking so many different medications, medicalize their menopause in the wrong way. It's just, I've lost count. So we need to sort of wake up to the fact that women can't be gaslighted anymore. And I feel that there is a shift, not just in the UK, but globally, that women are understanding. And my work as a doctor is to help patients. I didn't sign up to be a doctor to help other healthcare practitioners or to be subject to bullying or harassment. What I did do was to help improve the well-being of patients. And if I can also improve their future health, then to me, that's, a huge positive, contribution to medicine that I'm doing. But I don't feel it should be just in the confines of my medical practice. I would be naive if I thought I could personally help 1.2 billion women worldwide who are menopausal. So I think there is this sort of team effort actually, and it's coming from the ground up, which actually is probably the most effective way of getting things done.
I think one of the things that I like so much that I have heard, and I don't have a lot of experience with the UK medical system or your private health system, but the conversations that I've had here with friends and colleagues that are expats, so UK expats that are implanted here in Australia now, and they talk about a more patient-led care in the medical system than it seems we have here. I personally, in my own health journey, have experienced very much you have this, so you need to take this, and that's the end of the story. And there is not a lot of dialogue back and forth along the lines of, is that okay with you? How do you feel about that? Would you like to try something different? Is that something that's a bit more unique to the UK? Is it unique to the private versus the public system?
I think it really depends on the individual practitioner, and partly it's the way we train. So it's interesting actually, when I trained as a hospital clinician, obviously it was many years ago, it was in the 90s, and people really did just write up medication on the end of the drug chart, at the end of the bed, drug chart, write it up, didn't really talk to the patient, just basically, you have asthma, you will take this, end of conversation. And some of it is historical, but some of it is the way we're trained. When I then pivoted and went into general practice, my trainer said, "Louise, you're going to be a terrible GP." And I've always been quite a high achiever. And I said, "But how? What do you mean?" He said, "Because you're not going to understand patients. You're not going to share decision-making processes with them." And I said, "What do you mean share decision-making?" He said, "Well, you have to ask them what they want." And I said, "Well, they haven't got a medical degree. How are they going to know?" He said, "Because listen to it. Just try. At the end of your consultation, when you've explained everything, say to them, 'How does that sound to you? What do you want to get out of this consultation? And which treatment choice would you like?'" And I said, "But that's madness." They would look at me like I don't understand what I'm talking about. Anyway, he was a really inspirational trainer, so I did it. And it was a really interesting, even simple things like someone had a barn door chest infection, coughing up green sputum, really high temperature. And I'd say to them, "Would you like antibiotics or not?" And sometimes they would say, "No, I wouldn't actually, because every time I take antibiotics, I have thrush and it makes me feel really horrible afterwards." So then I could explore what to do about the thrush and how important it might be for this person to have antibiotics. But actually, we can get on board with the thrush, and I can give the thrush treatment prophylactically and everything else. So he really opened my eyes to that. But there's still a real hierarchy in medicine. So a lot of the work I'm doing when I'm getting pushed back by other doctors, it's because they're endocrinologists or they're gynecologists, and they see me as only a GP. And when I try and say to them, look, I've got a first class honours degree in pathology, I've got distinction in my MRC GP exams, I'm a member of the Royal College of Physicians. Why do you think I know less than a consultant gynecologist who's just done the bare minimum? Like, it doesn't make sense, but there is this hierarchy, and I see it in other countries as well. And and then goodness only, we're actually asking nurses and pharmacists to look after women. Well, they're brilliant. We have quite a few in our team, and I really enjoy working with them. But again, it's sort of, oh no, menopause has to be looked after by gynecologists. Well, why? It doesn't make sense actually, because it's a medical specialty, because it affects every single organ in our body.
It's fascinating, and I really hope that we can create a shift in the approach to patient care here in Australia as well. And I do feel that there's a shift coming, and I know that there is, a lot of advocacy going on. I'm lucky to be a part of that. So I see the stuff that's going on in the background. I just hope that we start seeing it trickle out into the actual healthcare system as well, and with the medical practitioners. One of the questions that I was really keen to ask you was, 5 years down the track from opening your first clinic, what do you see that has changed in the UK in those 5 years? And what do you think still needs more work?
It's a great question. I think there's a lot more understanding. There totally is. There's a lot more unpicking of the evidence, which is great. There's a lot more women who are understanding what's going on. So that's really positive. And there's a lot more healthcare practitioners who are trained, empowered, really joining force. But, and there is a big but, there's still a lot of misunderstanding. There's still a lot of people who aren't able to get care. The stories that I hear every day on my social media, just in general, are harrowing. We had a lady 2 days ago who flew over from Australia to get help. She came to the clinic. She'd had an estrogen receptor negative breast cancer a few years ago, and no one in Australia, well, she couldn't find anyone to treat her. I mean, that to me is harrowing and disgusting, actually. She wasn't allowed to make a choice about her future health by any clinician over the other side of the world. And there's also, a lot of pushback. I've been to meetings where they're saying, Louise, your media attention of the menopause has to stop. We're overprescribing HRT. The pendulum swung the other way. We need to rein people back in. We need to think about CBT, cognitive behavioral therapy. We need to think about open water swimming. We need to think more about antidepressants. And these are people at high level that report to our government and NHS England. So that really, really upsets me. They're talking about let's allow women to do self-care. So we need to reduce referrals to GPs who are already stretched. Well, actually, if we treat people properly, we won't have all the comorbidities and the diseases when we're older. One of my best friend's mother just had a simple fall, but she's just now in a hospital waiting for her fracture of her arm and her leg to be mended. It's a doctor's strike over here. She's waited 48 hours, unable to have her operation. Now, she doesn't take HRT. And I'm not a betting person, but I can really tell you that if she had been taking HRT the last 20 years, it's unlikely she would have had 2 fragility fractures. She's otherwise fit and well, looks after herself. So, things like this, they've got to look in the long term. I think that's the other problem. And the other problem, I think, is that it's too much pharma involvement, actually. And big pharma don't want women to take HRT, because when women take HRT, they're healthier, they take less medication. And there is this big suppression of that. And HRT is so cheap. So that really worries me as well. I mean, as you know, I don't do any paid work with pharmaceutical companies, but there are a lot of menopause specialists that do. And there's a new drug that's coming out that's helping supposedly vasomotor symptoms that affect on the neurokinin receptors in our brain. They've spent like $2 billion on it. They've got to get this money back. So most menopause societies I know are being funded by this drug company. And actually, if you look at the evidence, it's not much better than placebo. We don't know the long-term effects of the brain. They're saying that people have to have regular liver function tests, so we don't know the effect on the liver. But we've got an evidence-based treatment that's just our hormones. Like, why are we trying to fix something when we've got the best treatment available?
Really good question. And I know that you are very vocal in the media and obviously on social media. How are you managing the frustration? I know that you have very high levels of frustration. I know that you spend a lot of time doing your headstands and yoga practice.
Yes, I do. Do you know what? I think it's down to my family, actually. I honestly, and I'm not saying this for sub story, I do not want sympathy. I'm not that sort of person. But I would have given up this job so many times, really, because it's not easy. And I go on the media just to use my brain and my voice. I'm not doing it for any, Dr. Louise Newson show. My podcast has had nearly 5 million downloads. I don't get paid a penny for it. I'm not sponsored by it. I often do it. Well, I do it in my own time, but often late at night. I'm speaking to a guest in another country. We've spent billion or over a million on Balance App. We spent over £300,000 on our education. Yet people keep putting hashtag chase the money on my social media. It's just frustrating. And I honestly, so many times crumble and say to my husband, I just can't do it. I'm not a business person. Even internally, it's hard in the business finding the right people. But what I have done is learned that, the truth comes out in the end, doesn't it? And I'm a very, very truthful person. I'm a very loyal person. But actually, my husband just keeps reminding me, Louise, who's going to help that woman that you've just seen in the clinic? Who's going to listen to it? Who's going to answer that direct message? I had a direct message from someone yesterday who'd reached out to me, and we gave her an appointment in the clinic, and she said, you've just saved my life. I've had 8 years of hell, and I can't even begin to tell you how awful it's been. I've given up my job. My grandchildren don't recognize who I am, and just the last few weeks of being on HRT, you've transformed my life. Well, it's wrong that these people have to reach out to a complete stranger on social media to get help. So I feel like I've got in it too far. And all I can do is anything, even with my children, when they've been bullied at school when they're younger, just surround yourself by the good people. Look at the people that are bullying you. If they're people that you respect, then maybe you should think about doing something different. But actually, the people that I respect are the people that are working with me, actually, and enjoying the journey and really making a difference to women. The people that are bullying me, actually, are people that are just spinning around on their own in a very small group, getting very frustrated. And as you said before, all I'm doing is allowing people choice. I'm not saying everyone has to take HRT, and I'm not saying it's HRT or nothing. I'm not saying everyone has to get up and do headstands in the morning. I'm not saying everyone has to stop drinking. I don't drink alcohol or drink caffeine, but that's my choice. Like, let me have a choice with HRT as well. And I think that's the thing that I think actually you can be personal to me, but actually it's not just about me anymore. It's about the millions of women who are suffering.
And I think one of the things that you touched on then that often I feel gets lost in the conversation around the work that you do is that you are, it appears to me, often treating patients that are at the extreme levels, extreme end of the symptom scale. You're not seeing women that are just having a few hot flushes and perhaps a little bit of disturbed sleep. You are, I listened to your podcast, this lady wasn't a patient of yours. You were actually interviewing her and her husband about her mental health journey, and hard episode to listen to. But what she experienced from a mental health aspect was so extreme and so heartbreaking. And I would imagine that, you are more often than not seeing women that are in those extreme situations.
Yeah, we absolutely are. I mean, we're a specialist clinic, and of course we do. We see a lot of people who've been under psychiatric care, and they're the people that gynecologists don't see and don't realize that they exist. And the problem is that, yes, they're a small minority compared to the huge number of menopausal women. But because the menopause affects 51% of people, even if it's only 5% or 10%, that's still in 1 in 10 or 1 in 20 women. And a couple of weekends ago, I visited one of my patients actually in a psychiatric hospital because with the HRT shortage, she stopped taking her HRT and had tried to kill herself twice. And I went to visit her, and the psychiatric hospital's full of middle-aged women. And psychiatrists don't prescribe HRT, yet they'll prescribe all these other drugs with little evidence, actually. And we know how important estradiol and testosterone are as neurotransmitters and help in our brains. So I feel like there's still a massive underservice to women, actually, and it's often the women who haven't got a voice. We're doing some work in prisons, and people are homeless. We've just done a survey on drug addictions, and some of the stories we're hearing from that, which we'll present soon, are really quite distressing. So it's the women who don't have a voice, who maybe haven't got social media, who haven't got an advocate to help them go to a healthcare practitioner. And we're doing a lot of work behind the scenes to really democratize menopause care even more and use technology to try and make it so that people can have better access to evidence-based care with paying less money, because that's really important. It shouldn't be a two-tiered system, and it's a complete postcode lottery of care over here, but it is over there, I know, for you in Australia.
It is, yeah, very much. Our the people in Australia that are most at risk and those that are regional and rural, because of the geography of the country and the lack of care and services that are available in those regional and rural areas. And it's just so heartbreaking. It's so easy for me to sit here with my privilege in the city and, tell people to go and get a second or third opinion if they need to. But for many people, that's just not an option. And that is really hard.
No, I mean, I've got a patient from Scotland, rural Scotland, so there's only one practice, and she's one of our patients. She's been transformed with the right type of treatment, but she said that her GPs, whenever they get a letter from my clinic, they just look at it, they go in a circle, they look at it, laugh, and throw the letter in the bin. And they said that clinic can't be trusted. Well, she's really good. She's a researcher. She said, look, I know everything that I'm doing. I've got had patient choice. I've been allowed to make a choice. I've not been pushed into anything. But actually, if you remember, before I took HRT, I was using crutches and I couldn't get out of the house. My life's been turned around, and it's up to me to decide. She's quite strong, but how about all the other people that are being told that and can't change doctors? And I feel there's a lot of unprofessionalism. If I was a cardiologist and had prescribed, a heavy duty cardiology drug for someone's arrhythmia, they would respect me so much. But actually, because it's just menopause and because I'm just a doctor, and because I'm a white middle class woman, I even said to my children recently, if I was a man doing this work, my goodness me, I'd be knighted. Everyone would be bowing down. Or if I was a hospital consultant, if my husband had changed career and became a menopause specialist, it would be the best thing since sliced bread. But it's just really unequal and unfair. And I think that's the problem. With medicine and healthcare, everybody should be able to have the same access to the same treatment, especially when it's evidence-based.
Yeah, the misogyny is real.
Sadly.
Now, there is a topic that I want to touch on with you, and this is one that is very close to my heart. And I know that it is an area that you've been doing some work in, and that is around the prescription of HRT, MHT, as we call it here in Australia. Anyone that's listening, when Louise is talking about HRT, it is the same as MHT here in Australia for women who have had a breast cancer diagnosis. Now, particularly an estrogen progesterone positive diagnosis, which was my experience. Now, you interviewed Dr. Avram Blooming, who is the author of Estrogen Matters, an absolute game changer of a book. His research, his studies into this are incredible. I think I experienced every emotion in my body possible when I listened to your podcast interview with him. That was the first time I'd really understood the work that he was doing. And it was everything from anger, because I have been denied MHT point blank, just no, you can't have it. And it was the first time that I'd had it really clearly explained to me that my cancer being estrogen positive didn't mean that estrogen had caused my cancer. And I'm a smart woman. I know my stuff, I research stuff, but I had never had it explained to me that that did not mean that estrogen caused my cancer. And so that blew me out of the water. And then to learn that by being denied the MHT, it wasn't just about symptom management. We're talking about the potential for dementia risk down the track. And I have a family history of dementia, for cardiovascular health down the track. I have heart disease in my family. I really want to explore this conversation with you a little bit, if you're open to that.
Yes, I am, absolutely. And I think it's really interesting. Actually, I was talking to a good mentor who's a doctor yesterday, and I actually wanted to do oncology. I am going to answer your question, but I wanted to actually become an oncologist. And I did some training, even as a junior, a senior sort of medical student. One of my final year projects was to work for 10 weeks in a big cancer unit, a breast cancer unit, actually, in Manchester. And tamoxifen had just come out then. Showing my age here, I'm quite old. And it was before the internet as well. Again, might be surprising to some listeners that there was a time without the internet.
There was a time without the internet.
And Professor Tony Howell, who I was working with, said, Louise, I just want you to write a little simple fact sheet about what is tamoxifen. So I said, okay, that's great. That's not going to take me 10 weeks, though. Anyway, what I did is I started to interview different women. And I sort of said, what do you think cancer means? And they said, it just means death. No, it doesn't actually. Let's just talk about, what it actually is. And what about chemotherapy? Well, that means hair loss and vomiting. I said, but what is chemotherapy? It just means a chemical drug. That's all. When you break down the word. I didn't know that. And they said, well, you've had your lymph nodes removed and your arm. What do lymph nodes do in the body? Well, I don't know. They just collect cancer. That's all they do. So I just went back to Tony and I said, look, people just don't know anything, actually. So don't be ridiculous. I said, right, your next patient that comes in, you say to her, what is breast cancer? And he did. And she looked at this lovely professor and said, well, I don't know. It's just something that's going to kill me, isn't it? And obviously, as you know, most women who've had breast cancer do not die from breast cancer. The prognosis, even in the 80s, was really good. But even now, it's so much better, which is wonderful, of course. So I said to him, I'm going to write a series of booklets. So that was the start of my medical writing career, actually, empowering people with knowledge. And I thought, wow, how wonderful, actually. So they can be involved in this consultation really well. And then the whole thing, we know that estrogen receptors are all over our body. They're in every cell of our body. And that's why estrogen is such an important biologically active hormone. So if I chop off my little finger, or if I take a bit of skin out of somewhere, or if I take a muscle out of my leg, it's going to have estrogen receptors on it. So if I have a cancer, it's likely to have estrogen receptors on it if I test for those receptors. Estrogen receptor negative breast cancers are the ones where they've mutated more, they've lost their receptors because they've become more abnormal. So actually, as you know, estrogen receptor breast cancers are associated with a worse prognosis with most women who have them because they're more aggressive tumours. Whereas the estrogen receptor ones, if you like, are the better ones. But people think they've almost developed receptors and it's been caused. So people that I spoke to said, oh, my consultant said it was an estrogen driven or estrogen caused breast cancer. Well, how can it be? If estrogen caused breast cancer, we would see it far more commonly in young women who have high levels of estrogen in their body than older women. And we also need to remember that before the WHI study, the big study that scared everyone away from HRT, before it came out, HRT prescribing, certainly in the UK, was double what it is now. But breast cancer incidence was about 1 in 12 women. Now, HRT prescribing has more than halved, yet actually breast cancer incidence about 1 in 7. So we can't really blame HRT for all the breast cancers, even if you knew nothing about science at all. But then you have to look at other risk factors for breast cancer. So we know getting older increases our risk of any disease, especially cancer. Some family history can increase. But because breast cancer is so common, most people will have a member of family who's had breast cancer in it. But the other risk factors are so-called modifiable lifestyle risk factors. So people who are overweight, people who don't exercise, people who drink moderate amounts of alcohol will have a small increased risk of breast cancer, like they'll have a small risk of any other cancer. And we know that obesity has overtaken smoking as the commonest cause or risk factor for any type of cancer. And that's because all these lifestyles, if you like, increase inflammation in the body. If we've got inflammation, we're more likely to have disease, more likely to have cancers. It's just a fact, unfortunately. But actually, estrogen is very anti-inflammatory. That's why it reduces risk of inflammatory conditions such as heart disease, diabetes, osteoporosis, dementia, even clinical depression is an inflammatory condition. So when you look at the WHI study, what's very interesting is the group of women that had a hysterectomy who only had estrogen had a lower incidence of breast cancer diagnosis and a lower incidence of death from breast cancer. And also, women who had developed breast cancer on HRT actually had a better prognosis, so a better outlook than those women that had never been on HRT. So there's one thing being diagnosed, there's another thing dying from the disease, if you see what I mean. They are quite different. So that's sort of the history about HRT doesn't really cause breast cancer. The WHO study that looked at the synthetic progestogens, there was a small increased risk. It wasn't statistically significant. We don't usually prescribe the synthetic progestogens. The natural progestogen has never been shown in a study to be associated with the risk of breast cancer. Even the risk with the synthetic ones is lower than any lifestyle risk, so it's still small. But when you look at women who've had breast cancer, wouldn't it be nice if we could go to lots of randomized controlled studies and say, oh, the group that took HRT either did worse or better? We don't have those studies because they've not been done. And a few that have been done were stopped early because they were being done around the time of the WHI study. Everyone was so petrified about HRT. And also they use the older types of HRT anyway. So you're comparing apples with pears. Some studies have actually shown there is some benefit. And it sort of makes sense because estrogen is so anti-inflammatory. It also induces something called apoptosis, which is programmed cell death. And there is some thought and a bit of evidence that if people don't have estrogen for a year or two after their breast cancer and then take estrogen, it might actually lead to better prognosis. And before tamoxifen came out, they used to actually give a high dose of oral estrogen to women who had quite aggressive cancers that were quite, actually pictures of the fungating breast cancers coming through the skin. There's no other real treatments. They gave them oral estrogen at a high dose, and you could literally see photos of the cancer was, becoming smaller and improving. But women didn't like a high dose of tablet estrogen. Of course, that made them feel sick and increased risk of clot. So they were limited. Obviously, that doesn't happen with estrogen through the skin. So the other thing is that whether women has had breast cancer or not, so for example, for you, you've still got an increased risk of heart disease, osteoporosis, diabetes, dementia as a menopausal woman. And I'm sorry that is alarmist for people, but it's fact. All I'm doing is regurgitating fact. I'm not making this up in my head. So then it becomes to what we've talked about a lot in this podcast is about choice. So I see women in my clinic who have literally been suffering for years with zero quality of life. They're getting recurrent urinary tract infections. They've been diagnosed with osteoporosis. They're more worried about their mental health and their memory and everything else than they are having a recurrence of breast cancer. So then it's up to them, not up to me. I'm not living their life every day. I'm not with them when they're waking up 3 or 4 times a night with horrendous bone and joint pains. I'm not there watching them at work not being able to achieve. I'm not there saying that they can't have any sex with their husband and their partner might have left them. I'm not there picking up the pieces when they have an osteoporotic hip fracture. But the oncologists are there saying, do not take HRT, do not. And often when they're looking at the data, they're looking at taking like an estrogen blocker or not having HRT might reduce the risk of recurrence by about 2%. Well, if you're in that 2 out of 100 women, then fair play, that's going to be great for you. But if you're in the 98 women out of 100 who are taking treatment that's going to give you no benefit, but actually possible harm to your quality of life and maybe your future health, then it's up to you to decide. And when you talk about statistics, they're so hard. And, I don't care if I was one of those women about the other 99 women. If I'm in a group of 100, it's about me. But actually, I also want to know about my quality of life. And some women we see who've had breast cancer say, do you know what, Louise? I would go through all that treatment again. I would have chemotherapy, I would have radiotherapy, I would have a mastectomy, because that's a walk in the park compared to the menopause.
Yeah.
Well, how can I, as an adult who is a trained healthcare professional, say, sorry, I'm making the choice for you. You can't have this evidence-based treatment. So we've been working very hard. The group of us that have been together regularly spent hours on this, doing something called the Delphi process, where you go through the evidence and you come up with consensus statements. And we've been looking specifically about women who've had breast cancer. So we've been meeting with oncologists, radiotherapists, breast surgeons, breast nurses, other menopause specialists. We've had some patients on the group. We've had a urologist who's very academic on the group, whose wife actually had breast cancer and had urosepsis a few times, or he even realised about her hormones. And we've worked through the process over about 18 months. So we've just about to submit it to publication. So we've got a series of consensus statements that we've all agreed on. And as you can imagine, it's quite hard getting clinicians to all agree. Mm-hmm. But actually, they highlight the uncertainty. And I think that's very important to share that uncertainty with patients. And we've also just So the obvious, like, women do have an increased risk of osteoporosis, and they will benefit from HRT for their other health, risks. And we don't know, it might increase the risk of recurrence. But, we can share that might, or it could, with the patients. Somebody I know who works with me was talking to another doctor at a meeting the day before yesterday, and they were being rude about my clinic. And she said, "Hang on, I work at that clinic. What's your beef? What's the problem?" I said, "Oh, well, that you just give HRT to everybody who's had breast cancer." She said, "No, we don't actually. We listen to them. We understand what's going on. We spend time with them. And actually, what we always do is give them a free follow-up appointment 2 weeks later to talk about any decision that they've made. We have a shared decision-making document that they can sign if they want to show that they feel really empowered. We give them lots of information, so we don't just prescribe HRT without thinking about it. Of course we don't. But what's really important, as you know, as a patient, is being listened to and being understood. And the other thing with HRT is it's completely reversible. If I prescribe HRT for a woman today and she takes it, and then she decides to stop, it's out of her system the next day. So she's completely in control. And I think that's important. People think it builds
So
up
it
and builds
clears
up.
out of your system that quickly.
Yes, well, if it's used as a patch or a gel for the skin, yes. I mean, obviously, if someone has an implant,
Yeah, that's different.
If you use implants, and one thing that we don't. So, and I think this is really, really important, especially as we know that women who've had breast cancer live longer, and most women who've had breast cancer die from heart disease and dementia, not from their breast cancer.
Mm-hmm.
And that's about HRT. But if you think about vaginal hormones, lots of women who've had breast cancer or are on treatments for breast cancer who are having recurrent urinary tract infections, really sore, painful vaginal, vulval symptoms.
Yep.
These women are denied vaginal hormones, for goodness sake, and all they do is, stay in the vagina. They don't go all around the body. So we need to be looking really holistically. And of course, we spend time thinking about alternatives. And there are alternative medications that might help the symptoms. They're not going to strengthen bones. They're not going to reduce risk of heart disease. So it's just looking at the whole picture, really.
Yeah, that's fascinating. And it's so encouraging for me to know that you've been doing all of that research, you're working with other clinicians and you have some evidence that you're going to be publishing soon, which is great. I would love to think that we will be in a place soon where women can have those shared conversations with their healthcare professionals and
it feels like things have changed. So I get sort of direct messages from people on Twitter, some of them who are quite abusive, who are other healthcare professionals, and some of them are oncologists saying, "How dare you? What are you doing?" But then when I've said, "Oh, should we just talk?" and I've spoken to them, they're like, "Oh, actually, I hadn't really thought like that. I hadn't really thought there's more to the woman than just a breast cancer." Not just, I'm not trivializing breast cancer, but and so actually there has been a shift because they say, well, look, in our clinic, we keep getting phone calls, we keep getting letters from GPs to say a lady would like to talk about maybe stopping her aromatase inhibitor or changing to tamoxifen or, looking at treatment choices. And the more sort of hostile doctors who like this medical patriarchal system find it very challenging. But there are others that go, oh, actually, this is really interesting. I've not thought like this before. And I know when we produce these consensus statements, there'll be some doctors that will absolutely hate us. But actually, I think there are others that will find them quite reassuring, and patients will as well, because it's just basically sharing uncertainty. And we have to think about, what does shared decision making and informed consent mean? And it means that we're allowed to share uncertainty with our patients. They are allowed to make a decision that might be different to a decision that we decide for them. And that's really, really important, I think. And there are risks of denying treatment. One of the things we're sort of working on is thinking, what are the risks of not taking HRT? And I think even for you as someone who's had breast cancer, you do need to have a bit of time to think, what are the risks of not taking it? Because I know there are benefits. The same as you should be thinking, what are the risks of never exercising? Or what are the risks of having a McDonald's every day? I still see someone, I saw someone in my clinic a few weeks ago who'd had breast cancer 12 years ago. And even her oncologist said, your risk of breast cancer now is the same as anyone who's never had breast cancer. So why are we denying those women hormones? And then we see a lot of women actually who've had breast cancer at a young age, So they've had a medical menopause because of their treatment they were given.
Yep.
And then their periods have come back when they've been in their late 30s, 40s. And the oncologist has even said to them, oh, you'll feel a lot better now. Your hormones have come back. And then age 47, 48, their periods stop. They become menopausal, have symptoms, come and see us. But actually, the irony is they could have carried on having their periods for another 3, 4 years until they were in their early 50s. And the oncologist would not have batted an eyelid at all. Because suddenly I'm giving low dose of hormones back, it's like I'm giving the worst thing ever. And so we have to sort of think it just doesn't quite make sense, actually.
Yeah, there's obviously, I imagine there's still a lot of fear hangovers from the WHI that are at
Yes,
play here, that and misogyny that is and patriarchy and all of that is still just at play here underneath, rippling away.
absolutely there is. And one of my friends has just been diagnosed with a very small breast lump. It's not, she hasn't had an abnormal ultrasound, so she's waiting a mammogram, but the breast consultant said to her, oh my goodness, you've been on HRT for 6 years. Well, that's a real concern because the risk really increases. And I said to her, but actually it doesn't. And the stats he's using are older types of HRT. And, her mother had breast cancer. She's got she drinks a fair amount. She's otherwise fit and well. But actually, how can you just say that? And I hear it a lot from other people. When they've been diagnosed with breast cancer, your HRT will have caused it. Well, that's awful. It's a disgusting thing to say to anyone, to put blame and shame on them. And even people who smoke, not every smoker is going to get lung cancer.
Lung cancer.
Not every lung cancer diagnosis is due to smoking. But the other thing that really upsets me though with this is that if I was a man and if I had prostate cancer, that was a small localized prostate cancer, they would remove it. They might remove my prostate glands, but they wouldn't give me adjuvant treatment. They wouldn't block my testosterone in my body. One of the reasons they don't do it is because there isn't really solid data that it reduces long-term mortality, but also because the men would feel lousy and awful. And when they give testosterone blocking drugs to men, it's often only for 2 or 3 years. Whereas now there's a move to give aromatase inhibitors for 10 years to these poor women. And you just think, well, there's a real gender inequality here. Most breast cancers get treated by removing them surgically. Maybe the radiotherapy and the chemotherapy does have a small improvement. The estrogen blocking drugs do have a very small, I'm sure you know the predict tool that you can put in your type of cancer when you have it all that, and you see these graphs, and if you see the percentage improvement with hormone treatments, it's very, very, very small. And it's balancing that with, well, yes, people will die from other reasons as well. It's not all related to their breast cancer. But there is, and I can't find an oncologist that will explain to me rationally why men and women get treated so differently when they've had a cancer, their breast compared to their prostate. And I think that's something we need to really address because, breast cancers are so much more common than they were. And a lot of women are over-treated and over-medicalized. And we know a lot of women will die with breast cancer, not from breast cancer. If you do autopsies in older women, up to about 10% of women will be found to have a breast cancer. It's not affecting them. It's not being even diagnosed. It's not the reason that they died. But the more we do the screening, the more people are aware. Of course, that's a good thing. But we have to realize, what do we treat it? Are we just treating it with a sledgehammer? When and it's difficult. Breast cancer. The word cancer is really scary. But if you think about osteoporosis, if someone's had an osteoporotic hip fracture, it's a 20% mortality in the year after having it. So 1 in 5 women will die after having an osteoporotic hip fracture. Again, it's a scary stat, but I'm just regurgitating the stats. Now, breast cancer diagnosis is not associated with 1 in 5 women dying in the year after. Yet, women who are denied HRT have an increased risk of osteoporosis. And I'm not saying they all will get it, but it's just things that we need to be aware and think of. And in medicine, we work in silos. The oncologists will look at their success rate based on breast cancer recurrence or mortality. They won't include, even a lot of the studies don't include other outcomes, such as heart disease or osteoporosis. Osteoporosis specialists will only look at the bones, they won't look at the bigger picture. And this is where women are being shoehorned into one or other specialty. without someone taking a step back and really looking at that person as an individual. And that's what's missing a lot with this joined up care that should be happening.
Yeah, and I think that is a great way to kind of tie our conversation up in a little bit of a bow, isn't it? And that is the theme that has kind of run throughout our whole conversation, is that every woman deserves personalized, individualized care that is a shared conversation between her practitioner and herself.
Yeah, I totally agree. And the other caveat I would say to add is that people can change their mind at any time as well. So what you decide today might be different tomorrow, might be different in a year's time. So just because you've decided no now doesn't mean that's no in a year's time, or vice versa. You might have decided yes to a treatment now and then change. Like we change our cars because we, want to try a different model or a different version. We move house, like
we change jobs. Some people change husbands.
Indeed, which is absolutely fine. So, and I think that's the other thing. Nothing is set in concrete. And I think that's really important to understand.
Yeah, I think that's a really good lens to put on it. And I think it's something that's not spoken about enough, is that it's something that you can start and then you can totally change your mind about. And there is no long-term harm done.
No, I often say to women, even whether they've had breast cancer or not, you can try some hormones. And because there's no diagnostic test that's reliable for the perimenopause or menopause, you can try some hormones, and then we'll review you in 3 months, see how you feel. If you're feeling no better at all, and every day you're worrying about breast cancer, don't take it. But then it's surprising the number of women that come back and go, wow, my life's been transformed. I can sleep, I can think, I'm singing in the shower, I'm just happier, I can work, I can, and I just would never stop it. Well, that's again for them to choose.
Personal choice, I think, is got to become much more important. Education, personal choice, and individualized care.
Totally.
Amazing. Louise, thank you so very much for our conversation today. I have absolutely loved chatting to you. I could chat to you for a whole lot more time. I don't know if our listeners would enjoy it as much, and I'm sure you have a whole day ahead of you that you need to get on with.
Indeed, but it's been great. It's really lovely. And thank you so much for you sharing your story as well, because I know that's going to help a lot of people, and it's not always easy talking about yourself. So thank you.
Thank you for listening today. I am so grateful to have these conversations with incredible women and experts. And I'm grateful that you chose to hit play on this episode of Dear Menopause. If you have a minute of time today, please leave a rating or a review. I would love to hear from you, because you are my biggest driver for doing this work. If this chat went way too fast for you and you want more, head over to stellarwomen.com.au/podcast for the show notes. And while you're there, take my midlife quiz to see why it feels like midlife is messing with your head.